from the Psych Podcast Network.
Well, welcome everyone to a Future of Mental Health podcast. And if you haven't noticed already, this is a different voice. And we're doing something a little bit different today.
Hey, yeah, I'm great to be here. Long-time listener. I know I'm your poor man's Patrick Kennedy, but today we're here to talk about.
That makes me Marjorie. Okay.
Well, yeah, right.
So I actually am a licensed professional counselor out here in Colorado and been in the field for many, many years in all sorts of settings, and have here at Psych Hub, I've been helping out in the background with the Future of Mental Health podcast, and today's my first on-screen time. I'm happy to be joined here with Matt, the head of clinical operations at Neuroflow. And Matt, let's learn a little bit more about you today.
Thanks, Paul. Thanks so much for the invite today. Such a pleasure to be here. I'm Matt Miclette. I'm the head of clinical operations at Neuroflow. So I'm a registered nurse by background, but have quite an extensive experience in kind of mental health and substance use policy work. And I've been involved in integrated care, specifically thinking about where the technology and the humans intersect. So we're going to get into it a lot, Paul, today as we get into the weeds, but really thinking about not just how do we deliver collaborative care more effectively, but thinking about ways that we can scale it within health systems to really broaden our reach.
Today, we're going to be exploring a new course being launched by Psych Hub on collaborative care and giving some information about why should you care about this topic and really why it's a game changer when it comes to delivering care and access to mental health in the US. And we're going to be using audio clips from the course. And then Matt and I will have a chance to give some further information, our take on why this is something important for you to be listening to and taking the course. We'll include clips from Dr. Un, who is the Chief Medical Officer at the Recovery Centers of America and former Chief Psychiatric and Innovation Officer at Aetna, which is a CVS company, and also Mark Avery, who is a principal at the Health Management Consultants. A little bit more on background. Psychiatric collaborative care is one of several models falling under this idea of integrated care. And the goal of integrated care is to incorporate behavioral health directly into the delivery of physical health care. So often people are more comfortable with the physical health setting and recognizing with stigma and other access issues, using that as a foot in the door to make behavioral health care more accessible as well. And for today, we'll be talking about behavioral health care as encompassing both mental health needs as well as substance use disorders. And the reality is, all too often, for a whole host of reasons, behavioral health care tends to have access issues where people may feel less likely to show up and go to and maybe even be able to get into behavioral health care. And by using the benefits of the accessibility of a primary care office, more readily making it safer, more comfortable, and easier to get in to see a behavioral health provider. And there is a growing body of evidence that this approach is making a difference for people to really move out of even separating physical and mental health. It's about health and dropping that artificial barrier between the two with one point of access. There's a cost-saving benefit, as well as taking a look, we'll talk a bit more about a resource limitation issue and how this gets around the limitation of availability of behavioral healthcare providers as well.
Yeah, Paul, I'm holding back over here because, anyone that knows me knows collaborative care is something that really gets me excited for all the things you've mentioned and so much more that we're going to go into today. Had the pleasure of working with Psych Hub to develop this course and getting together with the experts of Magellan Health and Neuroflow together. Just a little background on me and us, the way we think about collaborative care at Neuroflow, we're a technology company and we're focused on the delivery of integrated care. We're making it easier than ever to provide and scale the psychiatric collaborative care model, or CoCM, as you'll probably hear us refer to it today and in the course when you take it. So, just getting into it a little bit and what is it? This is a measurement-based and stepped care model. It combines various behavioral health interventions and strategies. And what I really want people to understand and come in today understanding is that collaborative care is not competing with some other integrated care models you might be familiar with, like primary care behavioral health or PCBH model, right? Instead, these are actually frequently blended together to get the right patient to that right level of care with the services that we have available. And what's really great, and Paul, you were just touching on this, but it's a great opportunity for these primary care providers to know directly where they're referring these patients. They'll be matched with the right resources and care they need by a care manager, and they'll be receiving treatment recommendations from a psychiatric provider, all while staying informed on that patient's progress. Gone are the days where primary care providers no longer know what's happening with their patients, right? They can refer them into this program and stay updated, know what's going on, and really be comfortable knowing that they're going to have the outcomes they're looking for. And why is maybe another good place to start, Paul, before I kick it back over to you.
Please.
There's just not enough psychiatrists, right? I don't think this is a surprise to anybody that's listening to this podcast. But, we roughly have enough psychiatrists today to meet about a quarter of our need. Collaborative care is designed to have a caseload supervising psychiatrist that oversees a whole patient panel. And by providing consultations, we're able to then provide mental health care to a larger reach in a bigger pool of patients. And maybe even one step further is actually being able to provide this in a primary care setting to break down that stigma, no longer having to wait in that waiting room of the therapy office, which quite frankly, I think a lot of us have felt and seen in our experiences.
Matt, there's so much you just shared that really speaks to me. And when I used to work in the emergency room doing crisis evals, and someone did not need to be admitted to the hospital, but the best we could do is send them out the door with a phone number for someone we knew they couldn't get in to see for a couple months. And this is such a powerful way to overcome that barrier of, like you said, to be able to spread out the volume of folks, the care that a single psychiatrist can provide. And as we talk about this model, I started out in physical therapy, actually, and working in inpatient rehab. And I'm grateful because that was sort of the model we used back then. You would once a week have a staffing sitting around the table, and you'd learn so much more about your patient by hearing from the other folks involved. And to hear this now applied to the primary care office, I think is long overdue. And the last thing I'm thinking about is the stats I've seen on the reason people show up to a primary care office, 70 to 90% are stress related, that this is the place people are comfortable stepping in the door to start their care. So this is where we have to meet them with this model for that behavioral piece as well.
That's right. It's about meeting folks where they are. And that's really how the model's designed. And I'll share one quick anecdote too. My background's from military medicine side. And not only did we have to go into that behavioral health clinic that was on base, I mean, you have your name and rank on your shirt, right? There was so many barriers to really getting in front of a therapist and getting the care you needed. This is all about streamlining it. And if I could be a little cynical too, because I know, Paul, we want to talk about patient outcomes. There's a tremendous business value here as well for our healthcare leaders that are listening. Whether it's reimbursement codes or thinking about your value-based contracts, there's demonstrated cost savings benefits and improved patient outcomes that our payers are looking for here.
It's a win-win. Yeah.
Absolutely. These programs are generally pretty short, right? So patients are generally in collaborative care, 3 to 6 months. It can certainly be longer, but you see these cost savings of 5 to 10% over 2 to 4 years. That's quite incredible from any other interventions we could be delivering, particularly in primary care setting.
Well, and then we can put the funds where they'll have the most impact. And so we're not wasting money with inefficient models. And so we can really target where is it going to have the best effect. And I'm also thinking about the message it sends to a patient around, my doctor approves of this. My doctor is the person I trust. And so there's a bridging now that brings in the behavioral health care case manager and the psychiatrist as, I can trust them because they're in this location and they're working together. So it really works towards normalizing and lessening stigma.
Absolutely. So few of our patients are going out and making those referrals when they're made. And that warm handoff and actual connection and understanding that PCPs involved with care are all things that are making sure that we're getting a higher percent of our patients into any care. So there's a tremendous value there. Absolutely.
Well, Matt, you've sold me just in our brief conversation so far and the value of the model in this course to learn more about it. And how about we jump into some of our audio clips?
That sounds great.
And I think the first one is you, perhaps?
Oh, they haven't heard from me enough already. Yeah, I get it. Yeah.
So our first one will be hearing from Matt. about why he is so passionate, which you're already hearing thus far, but why he's really getting behind this approach and why we should all be taking this course.
What gets me so excited about collaborative care is really finding ways to break down the stigma of getting mental health treatment. Being able to treat mental health in the primary care setting is so important. What that's going to do is increase access. We know people like LCSWs and psychiatrists are incredibly valuable resources that we can't meet demand with meeting one-on-one alone. Collaborative care allows us to extend their abilities and consult over a larger group of patients to make the most of their time and effort. Providers should want to get involved in collaborative care because it's the future of mental health treatment. Whether you're in a value-based care or a fee-for-service model, collaborative care has the impacts that payers and insurance companies are looking for in terms of reducing total cost of care. It is an effective program that makes patients feel better physically and mentally and has decades of evidence now to show that effect. So getting trained will not only help your patients and not just help your practice and the bottom line, but really help you be a leader in healthcare, and particularly in delivery of mental health care in the primary care and physical health settings.
Well, Matt, I think you really have taken it home now in that clip and gotten a sense of not only why you're passionate about this, but also the why behind providers really need to get behind it as well. That there is the evidence behind this approach is going to be a better outcome. And that's what it's all about, right? For us providers, how do we get a better outcome for our patients?
Yeah, that's right, Paul. And we're so excited to get primary care providers involved and trained because this isn't meant to be another burden on them. Collaborative care is actually much more of a lifeline where now they know that central source they can be referring into and feel comforted knowing their patients are getting the care they need. So it's so exciting to get this training out to them.
And Matt, you bring another point to mind. I'm flashing back to the past positions I've worked in. And when I used to have to go up onto the medical floor for doing a psych eval, and so often that the medical staff, due to no fault of their own, weren't necessarily trained in someone showing up in a certain way, certain symptoms and behaviors. And this way, they have a partner that can help them to better understand and help to shift that person into being more collaborative themselves with the medical staff. Right. And so I think you raised a great point on making this really we're partnering with, we're not replacing or hopefully lowering the barriers for them to deliver their medical care.
That's absolutely right. One more quick antidote, and we can click over maybe to our next clip.
Okay.
I recently had a conversation with a pediatrician and talking about doing pediatric psychiatric collaborative care. And after speaking with him and describing this model, he talked to us about respiratory conditions and asthma and how it used to be that when a child had asthma, we were referring out to a pulmonologist. And more what they were doing is actually bringing those pulmonologists in to do consultations and helping these pediatricians understand how to treat this respiratory conditions in the clinic. And that's really the support we want to be able to provide, where this begins to become something normal, where, right, when we can treat these mild and moderate conditions effectively in the primary care setting.
Well, I can't help but then share about this sense of if somebody has depression, they're not managing their diabetes. If they have anxiety, they're not managing their blood pressure. And so we really can help increase the effectiveness of what the medical staff is providing.
That's exactly right.
Well, let's jump into our next video clip. And this one is from Dr. Un, the Chief Medical Officer of Recovery Centers of America, and hear more about his take on collaborative care.
I'm Hyung Un. Behavioral health disorders are very common disorders, and yet getting care is difficult because of stigma, because of the complexity of behavioral health care delivery system. When a primary care physician refers a patient to behavioral health, only about 50% of them actually make it there. So we have tremendous issue around access because of that and because of stigma, and also because of provider supply. We don't have enough behavioral health providers and enough psychiatrists to be able to meet the demand. And what collaborative care does is it creates an organized, team-based approach where we can promote evidence-based, measurement-driven care for a group of people who really need that care. So I've been very focused on integrating behavioral health care with rest of physical medicine. I've had a 20-plus year career focusing on that. And the Collaborative care is really the most comprehensive model of care, and I've been focused on getting the policy payment set up for that, and then to really support our provider community to disseminate and adopt collaborative care.
Thanks for Dr. Un to be participating in this course. You'll hear a lot from him in the program when you go through it, really highlighting some of the key points here that these conditions are common in primary care. And more importantly, personally, seeing leaders like Dr. Un and Dr. Caroline Carney, who is involved in this course, and others taking leadership roles to promote a model that we know is going to be effective.
Yeah, and I'm thinking about change is hard. And you mentioned earlier about not wanting to be a burden on the primary care providers. And change unto itself, it's going to take a little investment of energy and effort. And having leadership like Dr. Owen and Dr. Avery speak to this is worth the effort. It's going to not only be beneficial for you and your staff, but again, better patient outcomes, and encouraging that with this little bit of front-loading effort, it's going to pay back everyone in the long run.
Absolutely. Absolutely. And I think maybe this is a good segue, because I think we've been talking a lot about it from the perspective of the primary care provider. But who we're going to hear from next is Mark Avery, who really has a great perspective on that psychiatry side, and why psychiatrists are also really interested in getting involved in this model, and why they're so important to making sure that we're successful when we deliver it.
Awesome. Let's jump into hearing from Mark Avery.
My name is Mark Avery. I'm a psychiatrist, and I'm a principal consultant at Health Management Associates, where I've been for the last 3 years. Prior to that, I was at the University of Washington in the Department of Psychiatry, and also for a time was associated with the AIM Center there. I was a longtime medical director of a community mental health center in King County in Washington State. And part of the work that we did at the time there was we provided consultation services to a number of the primary care clinics all across the area that my program served. And we really struggled first with finding psychiatrists and behavioral health clinicians that were even interested in that kind of work. But then on top of it, really struggled with the models of care and staffing, being able to provide enough services in those clinics to really have a meaningful impact. And that went on for several years. And so later, when the University of Washington AIM Center approached my program and was talking about the idea of implementing collaborative care, I really jumped at it. So I was one of the consulting psychiatrists that worked in that collaborative care program in Washington State. And so we had between 15 and 20 psychiatrists serving as consultants in that program, and I was one of those psychiatrists. So I oversaw the care of multiple care coordinators. I actually worked half-time in that program, and at my peak, I was overseeing the care of, under collaborative care, of about 1,000 patients. One of the biggest unmet needs is there just weren't enough resources, enough behavioral health services to serve all the patients who needed those services in the populations that we served. And so, we know that in the primary care setting, depending on the practice, somewhere between 10 and 20% of patients present with some sort of behavioral health component to any of their visits. And we really struggled with being able to provide services to all those people. And of course, there's lots of research that shows as a system all across America, we don't, where there's huge gaps in care for people who need those services, and we were no different. And then on the other side is the workforce side of things. We also struggled with just finding and having the staff to serve those patients. And then just having a model of care. Once we did solve those two programs, what was our model of care? How were we going to serve those people effectively? So all three of those things were really urgent struggles for us.
Hearing Dr. Avery speak, I am thinking about burnout, which it was an issue before COVID, but even more so now. And this is going to add to the shortage of people either retiring or choosing to not be involved in direct care. We need more ways that we can meet the demand with perhaps less people. And so really hearing the power behind this collaborative care model from Dr. Avery's experience, that this is a way that they can feel and one of the aspects of burnout is diminished sense of personal accomplishment. And what I'm hearing is, there's more people being treated in a way that feels meaningful and valuable in that consultant role.
That is so right on, Paul. And even beyond that, there's actually a lot of evidence to show that when you work in these team-based models, there's actually much higher sense of that purpose and overall satisfaction with care. So primary care providers and people who have been delivering collaborative care have routinely said that they actually have higher satisfaction with the care that they're delivering. So not only making up for the losses we have, but thinking about retention and retaining the staff we're maintaining.
Yeah, excellent. Well, let's continue to hear more from Dr. Avery about how the value he's found in this approach.
Well, first of all, no one had ever heard of collaborative care in the system at that time, and especially the primary care teams, it was a big transition for them to go from non-team-based primary care, which most of them were non-team-based, into this whole person team-based model of care. The second biggest challenge was then, as I mentioned earlier, was finding clinicians out there that were interested in doing this kind of work. Because let's face it, it is a different way of providing behavioral health care. We had to go find people and oftentimes train them in how to do this model of care. The third challenge was that a lot of these programs actually already had some sort of behavioral health services in place, oftentimes in what we refer to as a private practice model of care. They might have been working in the medical clinic, but they really operated much like they had a private practice down the hall. Those people didn't just have to learn collaborative care, they had to learn how to transition their current models of care into that, which is oftentimes harder to do. And so that was a big challenge. So those were all people challenges. The last challenge, which was also very interesting, is there's a technology challenge for collaborative care, because one thing interesting about this model is it leverages technology through the use of clinical registries, for instance, to help keep track of our patients. And in every implementation project I've ever been in, solving the how are you going to address that technology issue is also a big challenge.
So Paul, we just heard from Mark Avery and really discussing some of the challenges around the technology needs here for collaborative care.
Yeah.
Collaborative care is not new. It's been around for well over 2 decades. We have 90 random controlled trials, actually far beyond that at this point.
Wow.
Yet it's not scaling, right? And so I hope the question would be why. And a lot of that has to do with a lot of these burdens, both the administrative burdens and really the technology needs to both manage the data, identify these patients, and how to manage that patient registry he's talking about. So, that's a lot of what I get to work on every day. And that's why I love this topic, is really helping to understand that these registries are something that used to be Excel files that we saved to our desktop, if you can imagine that.
Wow. Okay.
For most organizations, that's still the case. So we're talking about very rudimentary tools to deliver a fairly complex model. But now we're getting to a point where we really do have specialized technology and support that make this much easier, not just for managing outcomes and things like that, but also being able to count our time, because this is a time-based model where we have to think about care management time in order for billing, where we have to think about, how do we support and get resources in front of patients when they need it? And technology is going to really, really set us apart and be able to scale this in the long term.
Well, man, I'm going to date myself a little bit, because when I started back in healthcare 30 years ago, it was paper and pen and the plastic binder at the nurse's station. And I initially was not into tech because I went into healthcare. That was not going to be my area. And to really see, especially in the past 10 years or so, how tech is becoming that enabler of models like this. And really can't do it without. And so I appreciate the effort that you and Neuroflow have made in how do we make this more approachable and we lower those barriers so that our providers can more easily put it into action, that they don't have to problem solve for that piece. That piece is being worked out for them.
That's right. And too often we think about technology as replacing the human, right? And replacing our therapists, when really how I think about it, and certainly my team thinks about it, is how do we complement the human? And how do we make their workflows easier and be able to spend more time with patients and reinforcing those activities that they're they're doing with them. So that's how we think about it. It's a complement instead of a replacement.
Yeah. How do I free up? And you think about why do we go into healthcare? It's about focusing on a person, helping them to improve their life and ease their suffering. And if I could be freed up in some things that tech can handle for me, now I get to really, again, back to that sense of personal accomplishment, purpose, meaning. I get back to why I want to do this work to begin with. And this model really supports that.
That's exactly right. And that's how we have to think about this is, how do we reduce those administrative burdens and really spend the time on the patients so we're getting the outcomes that we want to see.
Matt, you and I can talk all day on this. We better stick in another clip at this point. So let's hear again from Dr. Un about the benefits of collaborative care.
The reduction in provider burnout, having to deal with behavioral health issues in a very busy primary care office without resources and without expertise is challenging. And so having behavioral health experts and behavioral health care manager support the primary care in its office has, I think, decreased the burden for primary care physician. Second, it has allowed psychiatrists to practice in a different way. So not having to see every patient, but being able to be involved and engaged in providing their expertise through the behavioral health care manager and through infrequent contact with primary care physician. They've been able to scale their expertise and make it more available. And for the patients, it's you get to get the care in the primary care setting with your trusted primary care physician. And that's really important because of stigma. Very often people wouldn't go to a behavioral health specialist. And so you get the care with someone you trust and without the associated stigma.
We just heard from Dr. Un again about, trying to manage these behavioral health conditions in a busy primary care practice. And I almost laughed because I know how taxed our primary care providers are. And, this came up briefly, Paul, when we were chatting about it earlier, but this is about supporting them. And when I go speak with health systems, that's the first thing I want to come out of my mouth is that we're here to support the primary care providers by giving them a resource that they didn't have before. And when you think about those patients that are in your office for 45 minutes because you don't know where to direct them and what you can do for them, and you want to so badly, you now have that direct stream of what you can do and a trusted individual that will take care of it for you.
And I'm thinking from working with providers, actually doing courses on burnout over the past few years and how much they tend to feel sometimes siloed and they want to do more. And so being able to provide them someone just down the hallway that they can immediately consult with, and then also that monitoring piece that the behavioral care manager can provide. I'm just thinking about the number of the stressors of more and more requirements coming from all sorts of different sources, and to directly give someone access to a powerful tool like this, I think is a game changer. And I'm just thinking of some of the doctors that really looked just before COVID, just wrung out and sometimes defeated and tired with more and more demands.
Yeah.
To be able to step up and say, no, here's something that's going to give you more lift, further reach. It's going to magnify what you can do. I almost think of why not? Why not give it a shot, right?
That's absolutely right. And, we're going to hear again from Mark Avery, and what he's going to really talk about too is how this also empowers psychiatrists to really have that sense of purpose and have their fingerprint on affecting large communities. So let's turn it over to Mark and have him share his thoughts.
My ability to touch more patients just dramatically increased. So let me give you a good example. At my community mental health center, we had about 10 psychiatrists, about 3,000 patients. So each one of us had an active caseload of somewhere between 200 and 400 patients. That was our caseload, full time. And after I started doing collaborative care as a consulting psychiatrist, I did it half time. And after about 6 months, I counted up all the caseloads of all the teams that I worked on, and I was working with an overall collaborative care caseload of over 1,000 patients at that time. And weaving that, by the way, in with a lot of the other work I was doing at the mental health center. So really with about a half time of my schedule, I was overseeing the care of between 5 and 10 times the number of patients that I was able to do in the specialty care model.
Dr. Avery speaks so well to his direct experience of the difference it can make. And, I also wonder, it's not just about volume, but it's also this sense of impact that working as a single provider and that lower number, I'm thinking was also, there was more work to do. And in this consultative role, I think it has this multiplier effect where you really start to see not only more people impacted, but bigger impact as well by working through the primary care offices.
That's right.
Make sense, Matt?
Oh, absolutely. I've seen psychiatrists and psychiatric nurse practitioners love these roles. They're much more flexible in their hours. This could be something that they're doing in conjunction with another program or things that they're working on. So it's a really great way to have flexibility in your job. And that's something I've seen allure to, particularly with our psychiatric providers. But, let's turn it back again to Dr. Un. This is, I believe, his last clip of our podcast. Okay. And he's going to be talking just a little bit about the impact of telehealth and thinking about how does telehealth and COVID-19 really relate to collaborative care as well.
Okay, let's listen.
The workforce is changing. Okay, I think the APA is training psychiatrists to participate in collaborative care. There's more receptivity on the primary care physician side to adopt collaborative care, and all the enabling tools are starting to be applied, whether it's financing, policy, expertise, workforce. They're all aligning, and the need is acute. And so I think that's going to just drive collaborative care forward. What happened during COVID-19, we switched from doing less than 1% of behavioral health care by face-to-face to 60% of behavioral health being done by telehealth. I think is an important sign. I think collaborative care can be done using virtual care strategies. And so I think the ability to scale collaborative care, I think, is going to also enhance acceleration of the adoption of the model.
COVID-19, Paul, I don't even know what else to say beyond that point in terms of the response we need for behavioral health. We've actually seen the identification of conditions double, and emergency rooms are just overwhelmed, and we're not doing enough upstream to really identify folks and get them linked up with care.
Yeah, we've talked about pre-COVID and now post-COVID, and I hate to use the term, this is the bright side, but the reality is the need has been there all along, and it's more so has been the sense of awareness of what can I do about how I'm feeling, and access and stigma. COVID now mental health will never go back to what it was before, but we've got to meet that demand of, okay, now that I know I need this, where do I go to get the care and the help that I need? And so this model really responds to that to make a ready-made answer. So as we said before, a place where people are used to going to already for their healthcare needs. Now we're taking down that artificial barrier, and it's not just physical needs. Where do I go for behavioral health? In a sense, one-stop shopping. And then telehealth just expands that even further, making access that much more convenient. So I really think we've moved into a new phase that's long overdue.
That's right. And I was out talking about collaborative care in March 2020, right? When health systems had nothing else on their mind but testing and treating COVID-19, and collaborative care felt like the furthest thing from a COVID relevant solution.
Okay.
And I'll tell you, that has changed drastically, even just months following the condition, because this is also something that's proven to be delivered remotely, where care managers, you don't need to be coming into the clinic to meet with your care manager. That can be done remotely as well. And being able to have the connection between the psychiatrist and PCP, again, all remote. So this was a model that was still able to support even during a time of COVID-19 where we were separated.
Excellent. Well, I think we've got one more clip from Dr. Mark Avery. Let's go ahead and take a listen.
The hope is that every patient within our communities, or at least within the populations that we are charged with serving, that every patient could reasonably expect that if they present with a behavioral health condition like depression, that they can trust that our system will offer them a safe and effective treatment package that will help them to get better. And just as importantly, that system of care will continue to keep track of them over time so that they don't fall off our radar screen and run the risk of relapse. That's my vision. It's a vision for healthy communities, and I think collaborative care and similar models could play a very important role in that.
It really stuck with me, Matt, the earlier comment you made about you've been working in this for how many years, and the research has been out there even longer. And so often in healthcare, there are things that are data backing it up. This is a good idea to do it, but then it doesn't move beyond that. And what I'm excited about this new course from Psych is we've already laid out the case why this is a good model, and the clips from Dr. Avery, Dr. continue to reinforce that. We got to get this out of the research lab and into offices. And
That's
this
right.
course, is really an opportunity for practitioners to hear from people like you and our experts here about this is doable, and it's long overdue, and we've got to scale it up and scale it out.
My background, Paul, is actually in substance use policy, and what I found when I stumbled upon collaborative care and this incredible trove of evidence and how effective it is, it made me think of buprenorphine and some of the medications for opioid use disorder, which we know are so incredibly effective, right? We know this is how we can treat opioid use disorder, yet we're not scaling it. So a lot of my efforts in substance use policy were similar, where I don't need to do the research. There is no research to be done. We simply know these are models that can work. And it's now at this point, it's all about promoting them, scaling them, and making them more effective. So
I think about earlier schooling and how often the case is when I hear about something new, it's like, why didn't I hear about this before? I could have better practice, better outcomes. So why didn't I hear about this before? We got to get people talking about it and excited to make that investment. And again, a little upfront effort here to make a huge difference in outcomes.
That's absolutely right. And, I think this course is a great place to start getting some understanding, getting buy-in from the executive leaderships at your organizations to understand that this is something worth investing in. And we have the experts now, right? So whether it's coming through Psych asking questions to Neuroflow, working with the Magellan team, we really understand these workflows, and you don't have to start from square one. We're here to support you, and we're going to make this effective and treat your patients. And at the end of the day, nothing makes me happier.
Well, that's the beauty, that you don't have to figure this out on your own. If you're excited about it, there's a structure and a template that you can now apply, and then customize it to what your needs of your particular practice are. But again, you're not starting from scratch.
Paul, I'm probably remiss, and I got a little too excited today because we probably have not given enough shout out to the Ames Center at the University of Washington, who really has been the godfather of this model. And they still hold monthly office hours. And I am a frequent attender of those office hours, where you can get all of your questions on implementation and financing answered. So, I highly encourage people to check out their website, learn more, learn all that you can, because the more you learn about this model and about integrated care, the more bought in you're going to be, and hopefully just excited and energetic as I am about it.
Well, thank you for adding that, because just listening to Dr. Avery's experience of this and his learnings, to be able to learn from the best, that's going to make you that much more effective and efficient in a collaborative care model. So thanks for adding that.
Absolutely. Yeah, there's a lot of technical assistance out there, but it starts from ground zero, which is let's understand this model a little bit, what everyone's doing. And then from there, there's a lot of avenues to scaling this up and making this a reality in your medical practice.
Cool. I'm excited just from this conversation to consider about the possibility of this. I envision a map of the US and suddenly like little lights turning on for practices doing this. And then we just get the whole country shining with collaborative care model.
Yeah. One of my favorite podcasts is The Indicator from NPR, and they have the big air horn, right? So maybe we need the air horn going every time a site launches. And hopefully at some point it would get too loud. We'd have to turn that air horn off.
Okay, cool.
But that's certainly our goal. That's certainly our goal.
Cool. Well, Matt, thank you so much for joining me today and really getting the word out about this new Psych course. So I hope that after hearing us chat about it in the video clips, that everyone's excited to go sign up and take the course, and appreciate this opportunity to get the word out. If you would like to learn more about and take this course, please go to psychhub.com, and that's 2 H's in Psych Hub. And you'll see information about how to sign up with an account to learn more about collaborative care. And of course, then you have access to all our other wonderful courses for learning about how to be a more impactful practitioner.
Great. Paul, thank you so much. This is a lot of fun. I really appreciate the Psych Hub team and the great work you guys are doing.
Great partnership, Matt. Thanks.
Great. Bye, everybody.